We continue our series on monitoring hormone therapy, where we're trying to help you navigate the sometimes difficult question of which type of hormone test should we be using depending on the type of hormone and route of administration that we're using. So we want to compare serum, saliva, and urine, and in some situations no test at all is really going to help with the clinical picture all that much. So we want to be asking, how do we know what type of test to use for different HRT situations? And today we're going to talk about oral hormones, beginning with oral progesterone. So the one point that probably confuses this more than anything is that when you give oral progesterone, you don't actually give that much progesterone, which seems counterintuitive, but you can see in this situation you give oral progesterone, and at 2 hours you get a tiny little peak, and then it returns to baseline fairly quickly. But you can see that premenopausal levels are really up in this range up in here, definitely above 4, usually between 10 and 15 nanograms per milliliter, and so you're not approaching those levels at all with oral progesterone. And so that's important to note. If you compare that with vaginal progesterone of the same dose, you can see that, and unfortunately they didn't measure the levels here at the peak, but probably looks, something like this may go even higher, but you're getting significantly more progesterone when you give it by a different route of administration than when you give it orally. So with serum and saliva values, the return to baseline is too fast to really measure it well. Now, if you're using a slow release, you may have a little bit more of a lag there, but the more important point to make is that most tests of this sort are inaccurately high, and we're going to look at that. So when you're using an immunoassay, so an EIA, and you don't have oral progesterone, the values are fine. They measure accurately, and that works well. When you give oral progesterone, you've got a unique situation in that your blood, your saliva, and these testing systems are flooded with progesterone metabolites that look an awful lot like progesterone. So if you look at the value at the peak, it's around 15 nanograms per milliliter. That's a perfectly reasonable luteal, young, healthy female type of a level. So if you look at that, you might think that you're doing well in giving a lot of progesterone. At the same time point, if you measure that same exact sample by a more accurate LC-MS value, you can see that the value really isn't very high, and the difference between these two is entirely a false positive. So you want to be really careful about your interpretation of a blood test or a saliva test following oral supplementation. Now, we mentioned that you're making lots of metabolites. In urine, that's all that we're actually measuring. Progesterone itself doesn't end up in urine in any significant quantities, and so what researchers have always done is measure surrogate markers. So beta-pregnenolone is typically used. In our laboratory, we've actually added the alpha or the allopregnenolone because that's actually a really important pathway. Over 75% of progesterone goes down these two pathways, and the beta-pregnenolone is typically measured. But it's the alpha pathway from where you actually get your biologically active compounds. So you get allopregnanolone, for example, which helps with sleep. So when women take oral progesterone at night, they make a lot of allopregnanolone, and that will help them sleep. So if you look at this particular woman, allopregnanolone is going to be down this pathway here, and you can see that the beta pathway is about 5 times the reference range. So a lot of that progesterone is getting pushed down the beta pathway, and the alpha metabolite is not nearly as high, and so this is a woman who actually has to take a higher dose of progesterone to get the same clinical effect. And so you're actually able to glean a little bit of information from the urine results, but keep in mind this does not reflect serum progesterone. So again, beta-pregnenolone is 5 times the reference range, so that would reflect a pregnancy type level of progesterone. You'd expect a serum level of maybe 40, 60, 80 nanograms per milliliter, and that's not the case because again, you're getting an overabundance of these metabolites with oral progesterone. So you have to be careful of the interpretation of any test with oral progesterone. Serum values don't increase much. The metabolites are responsible for some and much of the clinical effect. For example, allopregnanolone, but even the protection of the endometrium is likely somewhat because of these metabolites. And so the testing for serum and saliva in particular is of limited value, but even the urine results as well need to be interpreted properly in those situations. Now, as we shift to oral estrogens, it's a little bit different situation. The rise and fall of estrogen following oral supplementation is much slower, so serum and saliva testing can be effective. So if you look at serum results on day 1, so this would be your true baseline before supplementation, and you can see that before supplementation 3 weeks later, you've got a significant increase in estrogen, and then throughout the day you do get an increase, and then it comes back down, but it's a gentle enough rise and fall that you can test relatively easily most parts of the day with either serum or saliva. So in saliva, ZRT has shown some nice data showing dose dependence, correlation to symptoms, and I think one thing you've got to really note about particularly salivary estradiol is the analytical difficulty is high. I know ZRT does a really nice job, but you do want to be careful who you're partnering with because the test itself is just so very difficult. But when it's accurate, the salivary estradiol seems to correlate well following oral supplementation. Now, as we look at urine testing, this gets a little bit more complicated. So we're not just looking at, for example, estradiol, we're looking at all of these estrogen metabolites. So as we look in a little bit closer, what you can see is it appears that this person has an awful lot of estradiol, of estrone, and in particular estriol. Now this happens to be a person who's taking, I believe, a 4-to-1 ratio bias. So they're taking a small dose of estradiol and a relatively large dose of estriol, and that's reflected in the results. So you might think, wow, they're taking way too much estriol, but we need to be careful about this interpretation. This person took the hormone the day that they tested. Now, what does that mean? They're taking estriol, for example, and putting it into their stomach, and their gut has a chance, and their liver a chance, to conjugate this and put it into the urine before it gets into systemic circulation. So much of this number that you're seeing, this elevation, doesn't actually reflect systemic estrogen. It reflects first pass metabolism. And so we really want to be careful about that interpretation. And so those values are probably not very relevant. Now, as we move down and look at the metabolites, now those values are not going to be as subject to first pass metabolism. And you can see for this woman that her 16-hydroxy, her 4-hydroxy, and her 2-hydroxy estrogens are right in the normal range. And so you can deduce from that that she may be taking an appropriate amount of estrogen. So the other way that you can do that with urine testing is simply to skip the dose the day of testing, and then you get a better idea of what's going on in terms of their actual estrogen levels without the influence of first pass metabolism. But the reason that urine testing is additive in terms of its clinical value is more so for the relative distribution of these metabolites. We can see with this particular patient that she's got about 66% 2-hydroxyestrogen, and what's normal is about 71%. So as this 2-hydroxy number creeps down away from what's expected, then we're not favoring this 2-hydroxy pathway, which is considered the good estrogen. So that's a protective estrogen, and the reason it's protective is it's anti-estrogenic, but it also protects us against the harmful effects of the more potent 16-hydroxyestrogen, and in particular the carcinogenic 4-hydroxyestrone. So now this pathway is very complex, but what we will see at the end of it is that 4-hydroxyestrogens create 4-hydroxyquinones, or 3,4-quinones rather, and that can create a DNA adduct. So that can actually take a piece of DNA away from your DNA and damage it, and that is why it has carcinogenic potential. And so that's what we're really trying to protect ourselves against when we're favoring the 2-hydroxy pathway, when we're methylating these hydroxy metabolites, and that's really the pattern that we want to look for, particularly with oral estrogen, where you're making a lot of these metabolites. We really want to make sure that pattern is favorable, because those that make these DNA adducts, you can see women at high risk and women with breast cancer make significantly more of these DNA adducts than do their counterparts that are otherwise healthy women. So with oral estrogen, serum and saliva can work. For urine, you either want to skip the dose the day of testing or ignore the primary estrogens and look only at the metabolites to see what's going on there. So if you have any questions on this, feel free to email us, or if you'd like to contribute to this conversation, or if you have some interest in our testing. And please do see our other video tutorials on other hormones, other routes of administration. Thank you.